by Dr. Biju Raghavan. Biju, to introduce him, first of all, he is one of my best friends, and we have been together in palliative care for many years. I think more than 10 years. And presently, he is working as a consultant and head of pain and palliative medicine at Rajagiri Hospital in Alua. He has a special interest in communication sessions, and he has been taking communication sessions and workshop all over India. So I hope you will enjoy his session. Uh,
What was that? Thank you, Sunil.
yeah.
Hello,
Yes,
can you
we
Yes,
hear
can
yes,
me?
hear
Biju.
you.
Yes, thank you, Sunil, for the kind introduction. Just a small correction. It is 16 years now since we are together, and it's great to be back again with Palim India, and welcome everybody for today's session. All those who have logged in. We are already a little behind time, and today we are going to talk about communication skills, which is part one. We'll be talking about the basic aspects of communication skills, and next week around the same time we will be talking about further specialized areas of communication skills, which will be part two. So today we will be covering importance and role of communication skills in generally in healthcare industry, not necessarily only for palliative care, but generally whichever specialty of area you are in, whether you are a doctor or a nurse or a volunteer or any other professional in the healthcare industry. The general sessions that we're talking about today will be useful for everybody. We'll talk about some of the barriers, not every barrier, but some of the barriers to communication, and then a little bit of the do's and don'ts. Of course, you can't cover everything, but some important do's and don'ts. And then we will uh, try to figure out how to do a clinical interview. So, as doctors and nurses, we have been taught how to take a history. So, this will be kind of history 2.0. So, without much ado, let us start the session. Next slide, please. So, healthcare communication by itself is very challenging because people don't come to us because they want to come to us. They come to us because they are ill, they are in pain. So, the starting point itself is negative. They are coming with some discomfort, they are suffering. So, it is a starting point itself is negative, and hence, communication is going to be challenging even in the best of the healthcare circumstances. And also, we may have the best hospitals with all the gadgets and doctors with multiple degrees, etc., etc. However, whether we are helpful, whether we are giving satisfactory care is in the eyes of the patient and bystander. So it is not enough just to have lot of things in the hospital or lot of people. It is how they are perceiving our care, and that is why communication is very important. Next slide. So there have been the studies, and the study, uh, just quoting one study, but this is kind of universal. The patient satisfaction, for example, in this study, they found that for headache, so the patient's perception that they had an opportunity to tell all their problems in the very beginning, that had a positive outcome in the relief of headache. So that means no matter what kind of medicine you give, if you do not give them the satisfaction that they have been listened to, the outcome will not be as positive as you would expect it to. So, medicine and communication both are important. That means the medical, when I say medicine, I mean the active treatment part, plus at the same time communication. because that is where the satisfaction comes in, when both are optimum. Next, also we know that poor communication leads to lot of medical error, and medical error can be to the detriment of the patient, and it can also reflect on us because we can be sued, or sometimes because of medical error, people can assault healthcare professionals. So a lot of problems, the negative aspects of our healthcare issue, a lot of it is related to communication or lack of it. Next slide. And also, there is a financial outcome. There's a financial cost for inefficient communication in terms of how much you can be sued, and how much income loss can be as a outcome of poor communication. Next slide. And the problem happens because uh, nowadays I think things are getting better, because many of the medical colleges, especially in the West, have had uh, wo- have been testing communication skills as part of their curriculum. So problem happens that in our, at least in our country, we get tested for our clinical skills, but we don't get tested for our communication skills. And as a result, we are not taught communication skills. We are not tested, and when we come out into the field as uh, professionals, our communication skills, medical communication skills, often is found to be lacking. Now, what can be done about it? I think we need to change our educational system. I think a small change is happening. The government has proposed some communication skills into the curriculum. We hope things will improve. Next slide. So what is at stake here? In a doctor-patient relationship, communication has multiple dimension. With good communication, you can do good diagnosis, you can get better patient compliance when you explain properly, and when you have better patient compliance, uh, the outcomes are usually better, and then you have a patient and family which is more satisfied. When you have a patient and family which is satisfied, the relationship with you and the team gets better, so your team is also less stressed, happier, and and it also has an important bearing on the patient safety, which we already talked about. And yes, the chances of litigation also comes down. So we have to understand that we have to improve our communication skills for our own selfish interest. It is not just because it helps the patient and family positively. It's not just that it has a positive impact on your hospital or your team. It definitely has a positive impact on yourself as a person. So we learn communication skills for our own selfish interest. Next slide. Next slide. So that was what I was talking about. We learn it for our own personal and you know selfish interest, because it leads to better compliance. Good relationship means less stress and improvement in professional achievement, because professional outcome will be better, professional achievement will be better. And this is irrespective of whether you're in a private institution or a public institution, whether you're a clinician or more of an academician and a researcher. Good communication skills will help you improve professionally, whatever be your goal. Next slide. Of course, it helps the patient and family. It gives them a clarity among a lot of uncertainty, and also it gives them a sense of direction. Once they know what exactly is going on, then they know, you know, where are we headed, whether we are looking for a cure or we are looking for control, or we are not looking even for control, things are going very badly. Then they know how much resources they should be uh, you know uh, getting arranged for this. Many times we see that patient has a incurable advanced malignancy, and we see the family trying to sell their land, their house, and their cow for treatment, which is not going to get the person back. But they don't know that, and nobody told them that. So in the end, they are on the road, and the patient is also dead. So what happens to the children? What happens to the rest of the family? So a lot of these kind of tragedies that we see uh, can be avoided if we are better communicators. Next slide, please. And there's a lot of uh, differences of opinion within the society about medical issues. For example, our vaccine and corona is a good example. We, from the medical point of view, we are telling people to wear a mask, to sanitize this and keep distance. But somehow the message is not going in because there can be conflicting messages coming from various quarters. It's a challenge, but what we can do from our end is to communicate with the person sitting in front of us, that is the patient and family, and do it day after day after day. Ultimately, it's for our own selfish interest. Always remember that. Next slide. So, what are the barriers to communication that we see? There are multiple. We can't cover everything. Some of the barriers we'll talk about. Next slide, please. Next. Okay, so these are some of the barriers. This time, whenever I take a session on communication, many a time, especially doctors, they come and say that no, this we just don't have enough time. Please remember, you have to triage. Just like in an emergency, we do triaging. Similarly, on a day-to-day basis, you have to triage. For example, if you are seeing 100 patients in your OP, around major chunk of them will have only minor issues that you just need to give them first aid communication. Some of them may have major issues. For example, you need to break bad news, or you may have to manage a collusion. So those are some specific high skilled areas that you need. So you have to find time for them. You have to do them as an elective procedure. And sometimes you may have to do an emergency communication intervention. For example, if there is somebody who's getting very angry outside your OP, and there's a potential that this anger may get out of control. So that you have to drop everything and then focus on that and try to diffuse that. So it is how you learn triaging as a medical student, and then you practice triaging as part of your medical career when you are faced with large number of very severely injured, for example, after an RTA. Similarly, on a day-to-day basis, you can do triaging. And remember, communication is a team sport. You have to empower your colleagues, you have to empower your colleagues, you have to empower your co-professionals, doctors. It cannot be only the doctors or only the consultant who has to be a good communicator. Our nurses, our social workers, physiotherapists, pharmacists, everybody has to be taught good communication skills, including the security people, because sometimes their behavior can be upsetting to many patients. Because, as I said, people come to the hospital not because they want to come. This is not a place for picnic. So, the first of all, they are coming here because they are suffering. And if somebody behaves in a very high and mighty way at the gate itself, then it just makes them more upset. And probably after getting upset at many places, they may come to you and vent out all their anger at you, which is unfair. So everybody should be taught good communication skills. Next. Sometimes the patient can be a barrier. Sometimes they may be very timid. Sometimes the family may be very dominating, and they may not allow the patient and you to have a communication, because you may be asking the patient a question and the family intervenes and answers on behalf of the patient. So these are some of the or sometimes the patient may have some medical condition which makes communication difficult. So these are the challenges that we have to learn to overcome. And again, this today's session cannot sort out all of your problems. I'm just highlighting some of the barriers that we have. Next slide. So can we be barriers? Let's find out. Next slide. Sometimes our appearance itself can be a barrier with all our uniform and nowadays mask and all this PPE, etc. All of these things creates a barrier. However, we have to remember all these things are inanimate objects. If we have a positive body language, we can overcome the barriers of our appearance. We have to inspire confidence, not fear. And there's a thin line between those two. Our behavior, our body language should be inspiring confidence, not fear. Next slide. Next. Yeah. Okay. Go back. So we have to also have a change in our attitude, because from the time we have been medical students or nursing students, we have somehow acquired this attitude of, especially inside the hospital or inside our work environment, as we are powerful. And with power comes a little bit of arrogance. Sometimes, without even we knowing, our body language may appear to be little high and mighty. So we have to calm down. We have to step down. So our attitude has to come down. So one of the these are some examples of our attitude. Communication. I have got better things to do. So that is an attitude problem. Because remember, this is we are doing this for our own selfish interest. But sometimes our attitude becomes a big barrier. Next slide. Our lack of training. I mentioned that a structured training in communication skills is a rarity in Indian medical colleges. Slowly it is coming up, but it is still a rarity. Structured instructions in clinical examination, investigation, uh, interventions are all there in our medical training. But communication skills, a structured training in communication skills is lacking. Next slide. So coming to some of the do's and don'ts. So when you're talking about body language, the do is to make eye contact and smile. Even if you're wearing a mask, have a smile, because it shows in your eyes and it shows in your voice. Remember, your smile shows in your voice. So even if you are wearing a mask, does not mean you have to stop smiling. You have to smile, and it will create a positive energy. Many times, doctors in their personal life may be very jovial, but when it comes to their professional life, they become all very serious and don't smile with their patient and families. Next slide. Don't categorize people. Many a times we categorize people as somebody who's very important, so be careful. And that means that somebody who is not very important, you can, not be, very uh, caring enough for them. So these kind of value judgments should not be there. Accept people as they are. Doesn't matter what is their social status. They are all here for our care, and respect for people for what they are. That is the important message. Do not categorize people, because when we have this categorization in our mind, we create prejudices, and that becomes a barrier. Next slide. Don't ask leading questions. Your pain is better now, isn't it? So that kind of questioning will probably give you the answer that you want to hear, but that may not be the right answer. Instead, you can ask an open-ended question. How are you today? And you will get to know whatever the patient really wants to tell you. Because the patient is not in a pressure to give you the answer that you want to hear. So never ask a leading question. Next slide. Do not minimize anybody's problem. For them, their problem is the biggest problem. Oh, this is nothing. You look at the other person. So that means you are comparing also. So never minimize anybody's problem. For each person, their problem is the biggest problem, and never compare their problem with anybody else's problem, because for each person, their problem is the only problem, and that is the biggest problem. So acknowledge their emotion attached to the problem. Do not minimize the problem, but acknowledge their emotional experience. So these are some of the examples that I have put up. So, considering what you're going through, it is perfectly all right for you to feel that way. Or, if you are suffering so much, I can understand. Anybody in your position would feel the same. So acknowledge their emotion. Don't minimize their problem. Do not compare their problem. Next slide. Never ever give false hopes. Always give realistic hope, and that is the advantage of learning a little bit of palliative care, a little bit of palliative medicine for doctors and palliative nursing for nurses, because when you learn palliative medicine or palliative nursing, you realize there is always something you can do. There can be limits to disease treatment, but there is no limit to care. So always give realistic hope, and you can always give realistic hope of providing comfort, even if you can't provide cure. So that is the point. Never give false hopes. Many times I come across patients who have been told that you go to this doctor, that is me, and when you get better, you come back and then we will resume the treatment. The reason they have been referred is because the disease is advanced, uh, and hence no further treatment is possible. So they sent to me. But the patient thinks that I will do some miracle and then the person will get better, and then the patient can go back to the treating doctor. So that is the kind of unrealistic hope that some doctors give. Instead of saying that your disease does not seem to be getting better, so I think you go to the other doctor. That doctor will make sure that you are comfortable. It is as simple as that. But they say no. You come after you get better, knowing fully well that that person is not going to get better because the disease is progressing. The person became weaker because of the progressive disease. So when something can't be done for the disease, then how is that person going to get better? So that logic is lost in between, and the patient and even the family thinks that they know this. So this is a temporary thing. So this kind of thing should not be done. It is playing with people. Next, do not assume. Always ask people. When somebody says I'm scared, when somebody says I'm so afraid, when somebody says I'm so anxious, when somebody says I'm so sad, don't assume why they are sad, why they are anxious. Ask them, what are you sad about, what are you anxious about, what are you scared about, and then they will tell you. Because many times what they express and the reason why they express that may be totally different to your assumption, and sometimes it can cause a lot of problems also. So never assume, always ask. It's a simple thing. Ask and they will tell you. Next slide, please. And corona or no corona, I was also a little afraid in the beginning months, but now I have found out that with sanitizer I can sanitize my hands. That's what everybody is saying. So I'm back to human touch, and there is nothing more important than a human touch. You can sanitize your hands soon after you touch the person, but please remember, never give up on the human touch. Touch your patients and then sanitize your hands. And healthcare has always been a very, very difficult area, and it's becoming complex, and it takes a lot from you as a person. So take good care of yourself. You owe it to you and your family and society at large, because a healthy doctor and a nurse is an asset to everybody. But most importantly, you should be an asset to yourself. So take good care of yourself. Do a little bit of exercise every day, uh, you know, and then turn inwards a little bit, 10-15 minutes of meditation if possible. cultivate some hobbies, something different from your work and regular home. Have a pet, have a little bit of garden, listen to music, dance a little bit, do something, and stay connected. When I say stay connected, you stay connected with your friends, families, relatives. You stay connected with yourself, your inner self. You can stay connected with the divine if you believe in that, or you stay connected with nature. Whatever it is, have a feeling of being connected. You can be all alone and still be connected to the entire universe. So do take care of yourself. It is very, very important. You owe it to yourself, to your family, and to society at large. Next slide, please. So coming to the last part, how to take a history, little different from what we have been taught. So first is you greet. The greeting involves making an eye contact and smile, and you can nod your head. Along with it, you can say what is culturally appropriate. You can say hello, good morning, namaste, namaskaram, whatever. So this would be greeting. And make sure, even if we are dealing with somebody who is very, very sick, it is still important to greet that person every time the person comes in contact with you in the OP or IP. It is very, or home care. It is very important to have a greeting. You can have a serious conversation after that, but the greeting part, always have a smile. So get comfortable. For example, if they are in the OP, offer them a seat to sit. And if you are in an IP, you pull up a chair or a stool to sit down. It's very important to sit down, because when you sit down, you are showing, I'm here to listen to you. That body language is very important. Start the interview with an open ended question. So, how can I help you? Or tell me, or what brings you here? So that people are free to tell whatever they want to tell, and then listen. Do not interrupt, because many studies show that doctors interrupt within the first few 10-15 seconds of the starting of the listening part. Next slide. And while you're listening, you encourage the patient to talk also by maintaining eye contact, nodding your head from time to time, and also making encouraging sounds like mm-hmm, mm-hmm, okay. And you can ask some questions also. Okay, then, that kind of a thing. So this encourages the patient to talk. And while the person is telling you their problems, clarify anything that you did not understand on the spot. Don't say, okay, I'll clarify later. Because many times as the conversation move forward, sometimes we will forget about what needs to be clarified. Also, ask about what they understand about the situation. Now, this is very important, because here we are exploring the patient's insight about what is it that they understand is happening to them, or what is it that they know. That depends on what they have been told. So their insight may be perfectly in alignment with their reality, or it may have nothing in resemblance with their reality, or they may know some of the things, they may not know many of the things. There may be a lot of blank spots. It is very important for us to find out their insight, because later on, if we have to fill in the blanks, we need to know where those blank spots are. And that is why we need to find out what they understand. So usually in my practice, I ask them in Malayalam, I ask them, but I'll just say it in English. I ask them, so what have you understood about your disease? Or I'll say, what have the doctors told you about your disease? So this is one simple way of opening the door to the patient's insight. Then it's equally important to find out what their concerns are. What are they worried about? It may be that something is bothering them, or something is making them angry, and they are very sad about it, or they are anxious about it. So it's very important to understand what their concerns are. Next slide. And then comes often a very difficult part of sharing the information with the patient. Of course, this will in between there will be physical examination and looking at the investigation, or it may happen during the next visit or the next to next visit. But whatever, the general trend is once you have the information, then you have to share the information. And the most important part about sharing the information is you have to be honest about it. And not only you have to be honest about it, you have to convey it in a language that people can understand, because that is the crux of the matter. You have to, your message should reach the other person. And the most important part is no jargon, because we learn medicine in Greek and Latin. Literally, most of the terminologies are having a Greek or Latin origin. And as a result, by the end of our MBBS or nursing, we are very comfortable with Greek and Latin. And when we say the same language to people, it sounds like Greek and Latin to them. They will not understand. So it's very important to cut out the jargon, simple language, effective communication. And thereafter, we have to discuss the treatment option. And here it is very important that we listen to them. What are their point of view? What are their concerns about it? And as doctors, I always tell them you are more than a prescription vending machine. I also say that you are more than a waiter in the restaurant. Your job is not to give a menu of option and tell them you decide. You as a doctor, you are a friend, a guide, and a philosopher to the patient. That has always been the role of the doctor, to be a friend, guide, and a philosopher. You have to tell them what are the issues, listen to their beliefs, listen to their fears, listen to their social problems, financial problems, and suggest, considering all of these things, suggest what would be the best options for them, and then let them come to a decision. That may not be the best decision available, but that would be the most practical decision available. And this decision will be by consensus. Just like we take a consensus by having a medical board or having cross consultation with our other colleagues, it's very important for the patient and the family to have a discussion within the family with other important members in the family. This is what the doctors are suggesting. What should we do? So once we have given them a suggestion, not just a menu card of options, a suggestion that this is perhaps in the best interest of the patient, then we have to wait for them to have a discussion. And then this will be a combined decision, a consensus, a decision by consensus. So everybody is a stakeholder in that decision. That also gives us a protection, because it is not something that we have imposed upon the patient and family. And usually, the best solution may not work, but the most practical solution would work. And to arrive at the most practical solution, all parties should give their input, and a decision by consensus will lead to a practical solution. And then, once that is over, you summarize the interview and then you close the interview. Next slide. So how do we close the interview? We give them, we find out what would be the next time we are visiting, and whether that is a convenient date for both parties. That is for yourself as well as for the other people. Remember, not only your time is important, the other people, they also have a life to live. Their time is also important. So have a consensus on how we are going to move forward, when we are going to meet next, etc., etc. And then we close the interview by telling them that if there is any need, here is a number that you can contact. If you don't want to give your personal number, don't give it, but give them some number, hospital number, department number, some number, which which with which they go, and they have something in their hand in case they want to reach back. And in the last, there is a greeting in the end. Make eye contact, smile, nod your head, and then culturally appropriate. Bye bye, namaste, namaskaram, apashari, as in Malayalam, that I usually say. So I guess I'll stop here. And I don't know whether there is any more slide. Is there a next slide? Okay. So medical communication is a learned skill. Remember, if you want to sing, God has to be kind on you, because that's a talent. But communication skills is for everybody. Anybody can learn it. Next slide. So next session, that is next week, we will talk about communicating bad news. We'll talk about managing collusion and how to deal with an angry person. So I think we'll stop here. So I think that's the last slide.
Okay, thank you, Biju. The session is open for discussion. Anybody can ask your doubts or your comments or your experiences. Okay, Biju,
Yes.
Dr. Mahesh asked any paper or ebook for learned skill communication structure. Do you any paper or ebook for learned skill communication structure?
uh, I guess it is the simplest thing will be to check out on Google. I'm not aware of any recommendation. Are you aware of any recommended reading materials, Sunil?
Uh, Not really, but the one on communication written by Dr. Buckman,
Buckman, yes, Buckman is
yeah,
good. Yeah,
may be
I
available
think,
in Amazon, I think.
yeah, I think what is important is that it has to be relevant to the community we are working in. For example, uh, the when we're talking of the Indian context, there are certain peculiarities in the Indian context which will very different from, let's say, an a European context. Just as an example. So unfortunately, we don't have much of, at least in my knowledge, any text on communication skills. Sunil and I got trained by two very excellent teachers, but they were from UK, and we were taught communication skills during our PG program. And then over a period of time, Sunil and I modified those things to fit into the Indian context, and that is how uh, I had some interest in it, in communication skills. So started doing workshops and all. So that is what is something that I'm aware of. Buckman, yes, and that's a good place to start.
Biju, there is another question. How to deal with the talkative patient?
Okay, please remember, sometimes people are talkative by nature. Sometimes people may be talkative because they are stressed out. It could be anything. So you have to figure out what exactly is going on. Many times, if we feel that the person is talkative because the person is stressed out, allowing the person to ventilate is would be part of therapy. And I would encourage, in case you are short of time, as I said, communication skills is a team sport. You cannot be just one doctor or one nurse who's responsible for communication. Your entire team has to be. So if that person, if I see a person who is very much stressed out, and I'm short of time because I'm sitting in a OP which is busy, I will ask my social worker to come in the scene, and and my social worker is also trained in communication skills, so he will come and sit near me, and then observe the discussion, and gradually he will become part of the discussion, and then he will take over the discussion and maybe invite the patient to come over to his cabin and continue the discussion. while I get free to start seeing other patients. That I
That
just said as an
was,
example. Just as an
yeah.
example, we have to deal with the situation by situation. Sometimes I may have to gently bring the discussion back to the important topic for which the person has come to see me. If the discussion seems to be irrelevant and going in a tangent, we have to gently bring it back. For example, I will say, okay, but I just want to know more about that abdominal discomfort you were talking about. Can we let's focus on that a minute? So it may be a gentle way of bringing back the discussion. Uh, uh, that would be just two examples I would like to mention for the time being.
Uh,
Excuse me, sir. Dr. Mahesh here.
Yes, please, Mahesh.
Thank you, sir. Thank you. Sir, as you have told that all the nurse attendant or your team should be responsible for the communication. So, so we have to teach them in a structure. That's why I'm asking about the communication skill structure, because you have told that some of the college or some of the institution they have come with this course, so we need this course to teach our subordinate people. Thank you.
Uh, thank you, Dr. Ashish. No, what I meant structured is I said not in a way I would or Sunil or people who are into communication skills would want to. What I said was because of the new medical education policy, some elements basically they are more interested in teaching ethics and all, but some element of communication skills is coming in, but definitely it is inadequate. So definitely it is not. In a structured communication as we would want in palliative care the way we are taught, but it is possible, like you are you are part of this program today, and if you have not uh, been part of any other training programs, I would urge you to be part of this Pallium India's initiatives, because uh, we will hopefully right now because of this corona pandemic we are doing this on a Zoom, which is again something, but definitely not adequate. But hopefully eventually we will be back to doing workshops where we have hands-on training program, where we learn things by role playing, so that you get a feel of how actually so there are a lot of things that goes on. It is just a temporary the pandemic related some temporary halt in the structured training program that Palim India conducts. So once you learn, then it is easier for you to then start teaching your immediate team, and then gradually talk to your management and initiate that this is important part. It's not easy because not many people will be interested, and even in Palim India's program, when people come to learn the 6 weeks program, usually in not everybody is interested. I mean, you obviously seem to be very interested about it based on how you are asking the questions and all, but not everybody seems to be interested. They come to realize the importance later on, but when they realize there are so many things to be learned. So that is what I meant, that there slowly a structure is coming up in the Indian teaching program, but it is grossly inadequate. Plus, we don't
so
have enough teachers in communication skills.
Dr. Abir says sitting down during IP rounds is one of the best way of nonverbal communication. But he also asked a question: how many of us have time to do that?
Okay, so the answer to that is, if you are a doctor or a nurse, whatever time you are going to be there with the patient. For example, as a nurse, if you go to check the BP or put in a cannula, do that by sitting down. You don't have to bend and take a BP. Sit down and take a BP. As a doctor, as part of your rounds, if per patient you are spending 1 minute, you sit and spend that 1 minute. Don't stand and spend 1 minute, because that will have a qualitative impact on the care. They will feel that you have done something, and that sense of being cared for enhances if you spend the same time, but spend that sitting down. Don't don't spend 1 second extra. Only spend that much time that you have always spent, but instead of standing, sit down. And make sure you sit down at the patient's foot end, so that the patient does not have to strain their neck to look at you. Sit on the side of the bed, but nearer to the foot end of the patient, so that you can have straight eye contact.
So Dr. Sudha is asking empathy or sympathy, which is good.
Would you like somebody to feel sorry for you? Would you be happy if somebody were to feel sorry for you? So that would be sympathy. Nobody likes somebody to feel sorry for them, but everybody likes if somebody tries to understand your suffering, try to understand how you're feeling. So trying to understand how another person may be feeling, that attempting to know, that would be empathy. So that is always welcome. Sympathy, I guess, is not such a good thing to do. I hope that answers the question.
So I think we will move on to patient story. So today, Biju talked about the basics of communication, the how to start a communication with the patient, and what all should we do and what all should we not do. Uh, so these are even if we know, I think it is important to know what all we should not do, because these are some points which we usually make mistakes, and it is because we have a good heart, but the way we are doing is not correct. That's all. But that will make a big impact on the patient and family. So it is better for us to understand what all should we not do. And there are many barriers of communication, sometimes which we knowingly practice it, but at some time without our knowledge it come into scene. So we should be aware of this. Uh, so today's patient story will be presented by Dr. Vinay Jain. So it's over to you, Dr. Vinay.
Thank you, sir. Am I audible?
Yes, sir.
Yes, you are audible.
Okay, thank you. Good afternoon, everybody. My name is Vinayak, and I will be talking about a patient I had seen in January 2020. And this was actually during a visiting rotation abroad in the US. But I still decided to discuss this, because I thought, with the discussion around communication and navigating difficult conversations, it was a good experience that I thought I would share. And as Dr. Raghavan was speaking, I was actually jotting down some points because I thought they were relevant to the discussion of this case. So I'll start off. Next slide. So next slide. I'll just go ahead with the presentation. Next slide, please. We had a 65-year-old Caucasian female. This was in the US, of course, and she had been found unresponsive for around 30 minutes in a skilled nursing facility. So an SNF is basically like a nursing home with some a higher level of skill from the nursing care and rehabilitative procedures. So our patient was actually was staying over there, and that morning she happened to be found unresponsive for 30 minutes. And then she was brought to the emergency room. Next slide. So she had actually sustained a clavicular fracture 1 week before that. So she was in the hospital 1 week prior to that day, and she had been admitted for 3 days and then discharged. And during the entire course after that, she was doing well, as she was regularly doing. There was no change in her daily habits, no sort of symptoms at all, until the day that she presented, where, as I said, she was found unarousable. And the staff over there denied any history of fever, abdominal pain, any urinary complaints, weakness, sleep changes, or any altered mental status prior to this. Her past medical history, she was a known diabetic, and she had been diagnosed with NAFLD 2 years back, and she was being evaluated for the same. She was undergoing ascitic taps every fortnight, but she did not have any episode of SBP so far. And she had been put on the liver transplant list up to a year back, as far as I was told when on reporting. Next slide. So from the emergency, obviously, I have not mentioned those details because she was hemodynamically unstable, and because of her mental status, she was intubated, started on pressors, and she was transferred to the ICU, which is where this physical examination I've reported from. So she was not oriented to time, place, person. Her response was only, her eyes were not opening, verbal response was not there. Only seemed to response was squinching her eyes on painful stimuli. So I've characterized that as M2. Pulse rate was 108 and BP was 90/60, but she was obviously on pressors at this point of time on inotropic agents. She was afebrile. She was on vent settings on PEEP, and pallor was present, and she was icteric as well. So this was not reported or observed by the staff over there, but she was visibly icteric. On physical examination, she had a distended abdomen, so there was abdominal fluid and no organomegaly on palpation. And apart from being drowsy, there was no other abnormality detected on systemic examination. Next slide. Yes, so I've tried to put the relevant investigations over here. It's not a complete picture. I apologize for that. But obviously her LFTs were deranged. She was, her creatinine was high, but not as high as we would expect, keeping in mind, her liver decompensation and hepatorenal syndrome and things like that. Ascitic fluid, which was diagnostic and therapeutic tap was done much later, and E. coli was isolated. Urine culture was negative. In terms of treatment, she was on broad spectrum antibiotics, Lasix, as well as therapeutic tap for her abdominal fluid. Albumin was given. She was on pressors. So Levo, I meant to write norepinephrine. The brand name is Levo, and obviously Vaso, and both of them were being titrated throughout her time over there. She was on sedatives and Precedex as well, which might have also contributed to her hypotension. And I've written over here that the pressors were being tapered to see the response, and I will talk about it in a moment during my discussion. Next slide. So the psychosocial aspects, patient was a volunteer teacher for the underserved, retired. She was engaged in some form of employment prior to that, but I was not able to elicit that because of, several social factors. So I wasn't able to find out about that. Apart from that, what was a little, unique about this case, that her son, who was 40 years old, had received a liver transplant exactly 1 year ago. So during her hospital stay, it was actually the anniversary of her undergoing a liver transplant. And her code status, she had already determined it from before that she wanted to be on partial code. That is, if there was no improvement in her status over a period of 2 days, she said that she would want to be withdrawn from her care, from any interventions, life-saving interventions. Next slide. So our main concern over here, obviously there were not a lot of deficiencies in terms of, communication, because palliative care team had been brought on board right from the beginning. And, this was a patient who had been very clear about her code status. She wanted any life-saving interventions to be withdrawn only when there was no improvement. So, we were having good communication, regular family meetings and goals of care discussions. So it seemed that there would not be any problems over here. But it did have, and the biggest problem I think was, the fact that her family members, the son and the sisters, there was a huge disagreement on what to say as no improvement before withdrawing any sort of interventions. And, a lot of that was a source of, disturbance for, the treating team. Because, as they always say that, there's a differential diagnosis for a patient's medical symptoms, but there's also a differential diagnosis for a patient's anxiety. So I think this was something that Dr. Raghavan mentioned as well. And over here, the family was feeling very vulnerable because they had to make a very difficult decision, which was, playing into their hesitancy from, going ahead with the course that was being recommended. Next slide. So yeah, this is basically the end of my presentation. What I basically might have just missed over there was in regards to her course. She was in the ICU for 5 days, and at the end of the 5 days, finally a conclusion was drawn where she was withdrawn from care. This was after all her family members had flown in. The discussion, sorry. Okay, yeah. So the discussion points that I thought we could talk about was, the first thing was, of course, the disagreement on code status between patient's son and the patient's sisters. So I know in the previous classes we have talked about weak paternalism, and that was some concept that had come into play over here, because what was to be determined as no improvement in the patient status, because whenever the pressors were being reduced, they would see that as a good improvement. But in fact, we know that that might not be the best way to judge a patient's course of recovery. The next thing that I wanted to talk about was regards to narrative competence to counsel patient and patient families. We talk a lot about being culturally competent and sensitive, but our institutional protocols with regards to end of life care, they are not very, targeted or keeping in mind the person's, cultural beliefs. So in this case, for example, I did not know, I was not familiar with, their requirements. They wanted a specific chaplain, and even the other residents over there were not very familiar. So that definitely added to some amount of distress and obviously communication barriers moving on. And apart from that, patient's extended family invited judgment due to lack of decisions. And again, I know Dr. Raghavan said that our interactions should, not be categorizing, but it should also be non-judgmental. But I think due to the human nature of the fact that, the physicians and the residents who are working over there was some amount of, I would say negativity that was brought in the conversations, because the family members over there were not, going as per what we would want them to, and they were sort of fixating on things like adding more and increasing the antibiotic coverage, doing more imaging and things like that. So definitely a communication barrier from our end over here. And finally, I thought we could just discuss about if a similar situation was encountered in the setting of India. So again, as we were talking about, we cannot talk about communication protocols and structures in the West and see if they are applicable over here, because we have our own peculiarities. And before we had started the session, I think Dr. Avnish was talking about how ICUs are really a black hole in terms of cost. So this was actually one of the examples, I feel, where you see that if we had not determined appropriate goals of care, we would just be having the patient in the ICU, which would be draining their resources. So that was something that I felt we could talk about as well. But apart from that, I think my personal experience was that, we were adhering to a lot of, the do's and don'ts of good communication throughout the case. And, the patient obviously was, severely decompensated. And so there was very little hope for recovery. But all said and done, I think with regards to communication, it was a good experience in learning the, say, nuts and bolts of navigating difficult conversations. So yeah, I think that was about it. I don't know if I have another slide here. Thank you.
Thank you, Dr. Vinayak Jain. That was an excellent presentation, very relevant to the topic we have today. And the very pertinent points that you have brought up for discussion. And I would like this discussion to be open. Before you, I'm sure that you have put in a lot of thought behind putting up this points for discussion. And I'll be very interested to hear your take on it, because after all, you have the direct experience of the situation. But I would like to know from the other participants, what do you make of these discussion points that you have in front of you? Rajalakshmi, can you, just read the any messages, or anybody who is interested to make a comment?
Sure, sir. I will do it. So you can even unmute yourself and speak, or give your suggestions through the chat option.
Maybe let us go at it from point to point as it is put up on the screen. This disagreement on code status within the family. So let us not focus very exclusively on the code status, but even in the Indian context, we see disagreement on treatment, or whether to proceed with treatment or not, what kind of treatment, whether we should go for surgery or etc. So there can be difference of opinion within the family, and sometimes This difference of opinion can be very subtle. We may have to ask to find out, or it can be very, very open and maybe very hostile and play out in front of our eyes. It may play out in front of our eyes in the OP or in the IP. So I'd just like to ask the participants whether you have come across this kind of situation where you are in the middle of uh, kind of a civil war happening within the family, and if yes, then how did that get resolved? It will be very interesting to know. Would somebody want to speak on that?
If I can just like add to that, like maybe people might relate to this, that, you know, in such disagreements, we tend to rely more on like the medical facts, like plain, like which do not regard any emotion. So hard, cold facts and evidence is what we rely on. And sometimes that might help, you know, navigate that conversation. Invariably, we'll have to take the side of one of the sides in the family. Maybe in this case, the patient's son was what we were favoring because he was willing to withdraw care. But you know, it's still at the end of the day we have to go with what, you know, the overall family wants. We cannot proceed without you know, everyone's consent and without arriving at a consensus, even if it was medically indicated. So maybe if someone might relate to that aspect.
uh, Dr. Jain, have you ever considered that some of the other family member may sue you for colluding with the son and causing harm to my dad?
I have never ever considered that, to be honest, but
I have been a victim of that, so I can say it with my personal experience. So it is real serious matter because the conflict within the family, we may be the ultimate victim of it. As I said, good communication skills is a very, very selfish act. So resolving this inter-family dispute is for our own selfish interest. So uh, the father sued me for favoring the son, and both father and son were doctors for uh, you know certain decisions. Anyway, the judge then finally asked this father who sued me to have to have a good chat with his son and and put the judgment in my favor. Uh, thank God for that, and also very important because of meticulous documentation. Remember, good communication is also not about resolving conflicts; it's also about document everything. So never take this inter-family difference of opinion lightly. It's very important to resolve it. And usually, how I go about it, because I'm sorry, Dr. Jain, but I will want to know your point of view because nobody else seems to be coming up with any what do you call any personal experiences. So yeah, yeah, very Dr. Sheetal saying that very common scenario that close relatives are oh,
So know everything about treatment and agreed upon, but eventually some third person shows interest and end up beating a doctor.
exactly. So these are something which is very familiar to most Indian doctors. So I think that something that I usually say to the family when I see that there is no, I always say that have a consensus. And my usual uh, sales pitch, if I may put it that way, is because tomorrow within the family you should not be pointing fingers at each other and and causing the relationships to go bad. So I'm not saying I want a consensus because I'm worried about myself. I tell them that it is very important to have a consensus that tomorrow you don't finger point each other, and the relationship should not go bad. So that is how I put it. This is how I place it. This is for the family to resolve. But Dr. Jain, very interested to hear your take on that. How did you resolve it finally?
So, my experience in this is very limited, and I have never ever considered the possibility of, a medical legal case within the family members targeting the doctor, as you have actually experienced. Over here, my thought process initially, and of course, my involvement was just as a student, so I was not part of any decision making. But as part of the clinical rotation, when I was asked to justify my opinion, I felt that we could take the side of the son because he was the closer relative. So from a legal point of view, I felt that he would have more weight. His opinion would hold more weightage. And if, say, she was a widow, so if her husband was alive, then in those scenarios, we will listen to the husband or any partner or something of that sort. But then again, this is always something that I have, spoken about earlier also during our sessions, that when we talk about paternalism, we like, as you said, we put forward a menu, but then we have to also counsel them on what would be the wise decision from that menu. So I mean, my approach was that to like give them the options, tell them on what the correct what our recommended advice would be, but in the end go with the son because he obviously has a greater say over here. But again, like, I am not very sure if that was the right way to go about it.
Perhaps it was, considering the situation. And there is always something that we learn as we go along. So regarding when we are dealing with disagreement within the family, uh, have these meetings, have a consensus building, and please remember, we are doing this in the best interest of the patient, in the best interest of the family, and our best interest. We have to protect ourselves. We also make sure the family in future stay together. They don't implode because of the stress. Because the stress can build up if there is no consensus, and we have to direct them. The consensus should be directed towards a direction which is in the best interest of the patient, so the patient can be protected from futile medical intervention, and the best possible comfort and dignity can be provided to the patient. uh, I guess we will stop with that on that point. Regarding the the second point, would you want to say a few words on that?
So I brought that point up because I felt very disturbed because as a student I was taking history over there and presenting the case, but I was not able to I felt in order to give our best to a patient in a clinical scenario, we should look at them as having a life beyond. Like, this was a retired teacher. She probably went on Sundays to the library and worked with underserved children. So I think that gives some context. So that is what it gives some context to your care. So that is what I meant by narrative competence. And over here, owing to the hierarchical structure, I was not allowed to talk for a lot of time with the patient's son. So I was not able to gather those details and contextualize the patient. But more importantly, what made me a very disturbed, and this is something that we see uniformly throughout, that I don't know how applicable it is in our Indian setting where we have so many patients, but we talk about cultural sensitivity. But as I was mentioning, our hospital protocols and our institutional, formalities are not necessarily culturally competent. So it's an ironic that the new ATCOM module and all these new things in schools are telling us to be culturally competent. But when we go to the hospital during our rotations, everything is very medicalized and, secular in a way to speak. So I think that is also there's a huge disagreement between what is being taught or what is expected to be practiced and what is actually being practiced. So this was what I meant by the second point. And Spike's protocol, I just added there that, having a good setting and, adhering that protocol, again, the same protocol might not be enough, or there would be more to be desired from ourselves as doctors, especially in an ICU situation.
Right. For those who are not much aware of the Spikes protocol, it is a protocol with which hard, difficult conversations, especially communicating bad news, it's a structure which you can use to have difficult discussions. So those who are participating in this, do you have any comments on this? That our medical care is uh, lacking in being culturally sensitive. Remember, India is not one uniform country. We have different cultures, different language, different sensibilities, different belief systems. So, are we able to cater to this wide variety of cultural sensibilities? Anybody would want to make a comment? Rajlakshmi, are we having any comments on the chat?
Nothing yet now. No, we are not officially trained. That is what Dr. Archana says.
Yeah. So as I said in the earlier part that Dr. Jain also mentioned just now, the AdCom, which is now part of our medical curriculum, the new curriculum, it is the good part of it is at least something is come up, and we know that's a starting having something is a good place to start. It's always this option of building upon it, making it more relevant. So hopefully, with all of you, becoming sensitized to the importance of communication, more voices will demand that better skills on communication, on ethical decision making, etc., will become as important as anatomy and you know medicine and pharmacology. I have nothing more to add to this topic. This point, yes, yes, please.
Dr. Arsha?
I would like to say is I don't know whether in ICU setups for withdrawing of CRES, do you have the protocols are not very clear or what? Because when my mother was admitted in ICU and we came to the last stages and all, I wanted her to take her back home, but the protocols were not very clear of taking her back home. Like hospitals were not allowing me thinking of medico legal cases.
Uh, right, Asha.
Hello.
Sorry to hear about your personal experience, which was not a very pleasant experience at all, and not a very unique experience either. This is something that happens to many families of patients who are their parents or children or siblings or wives or husbands who are in that kind of situation. It's a terrible thing. Uh, Slowly, this topic is coming into the, it's still in the margin of how you care for terminally ill patients. Because right now, the only way we care whether somebody is critically ill or terminally ill is to put them in the ICU. ICU is a place where you provide critical care, and the whole purpose of providing critical care is for patients to come out alive out of it. This involves a lot of physical torture, medical torture. This also involves a lot of mental torture to the patient and the family. It also involves a lot of financial torture. But all of those things can be justified because here we are trying to save somebody's life. But when we are dealing with somebody whose life cannot be saved because that person is terminally ill with an advanced cancer or or an organ failure or multiple organ failure, or or any of those kind of situations, then torturing them physically, emotionally, financially is just not justifiable. It is even immoral. But then what is the option? Most hospitals do not have palliative care services. So how do you provide end of life care without the technical know-how, without people who are trained in these kind of things? That's why you end up clubbing all kinds of patients in the critical care, which is very unfortunate. Most hospitals do not have an end of life care policy either, because if you need to have an end of life care policy, you need to have people who are skilled, who are knowledgeable and skilled to provide end of life care. So that also gets dumped into critical care. So this is the problem. And then whether it is critical care or end of life care, you have to uh, have very good communication skills, especially for these areas. Very good communication skills are needed in emergency medicine, critical care medicine, and palliative medicine, because these three areas among the medical practices are known to be high stress areas. Unfortunately, we have very little at hand. But as I said, small changes are happening, and it is for each one of us to demand that things improve in our healthcare system. And hopefully, such experiences will come down in future, and we have a lot of work to do. I will stop at that. If you have any further comments, I'll be happy to hear them. But we have two more points to discuss. It's already 4:30.
So we have another question by Dr. Mahesh.
Mhm.
How to bring about uniform communication irrespective of different patient and family members' mentality and different geographical area?
Okay, there is nothing like uniform communication. You have certain guidelines. For example, easy to understand, when we were doing our MBBS, we were all taught uniform history taking. You find the presenting complaint, history of presenting complaint, past history of any diseases, family history, etc., etc., etc. We learned it in a structured way. But if you are a obstetrician or a gynecologist, or if you are a neurosurgeon, you are going to take two very different kind of history. But the your basis is what you learned is the history taken in MBBS. So similarly, you learn the basic structure in communication skills and you apply to the situation you are dealing with. So there cannot be a uniform pattern, but there is a certain guidelines that you learn and you apply to the situation you are dealing with. I hope that kind of gives the idea.
Sir, I
All
think
right.
we can move on to the next two.
All right. So the next point, Dr. Jain, would you, the patient's extended family invited judgment due to lack of decisions. Would you like to elaborate on that?
Yes, and I know that we are short of time, so I'll just quickly tell it in the interest of everyone. So, what I mean by this is that, implicitly the team, team of physicians, like explicitly they were saying that, we are hearing you, or we are sensitive to you, but implicitly from their behavior, it was very evident that they were being very judgmental, and this is unfortunate. And it was not because with an intention of malice, but because they also, as humans, felt really bad that the patient, a 65-year-old lady who might as well be their grandmother, was going through so much because the extended family was not able to make the right call. And just as an example, this was not always the case. As I mentioned, this was the 1-year anniversary of the patient's son having received a liver transplant, and he felt that he had taken the liver away. If he had taken the liver away from his mother, and if he had not done that, his mother would have been in a better position. So the doctors over there, who were actually more aligned to his emotions than the sister's emotions, told him that if they were parents, and if they had an option, they would still give it to their son rather than take it to themselves. So they were more empathetic to the patients, but more a patient's son, but more judgmental to the patient's sisters. And of course, that was not the right way to go, as you also mentioned, non-judgmental communication. And it was very visible implicitly. So even if, as you said, you have a mask, when you smile, it's visible; when you frown, it's visible through your non-verbal cues. So this was just one of those examples.
Thank you, Dr. Jain, Vinayak Jain. Because we're short of time, I'll just put in my thought on that. As doctors, we are somehow trained to focus on the patient, and hence we are empathetic towards the patient's distress, and we advocate for the patient. That is, our whole focus is the patient. I think somewhere we also need to expand our empathy to the family. They do not, as you said, they have no malintent. They just have difference of opinion. And having an opinion and difference of opinion is only human. And remember, more than us, they are definitely suffering more. So even though we have to be empathetic for the patient and we have to be advocating on what is right for the patient, we need to hold back a little bit, not be fanatic about it. And please understand that the family is also suffering. They need our empathy. We need to also listen to them. And many times, this listening and constructive suggestions is all that is needed to have a consensus. Many a times, just listening and allowing them to ventilate helps them come to a consensus. So just expand your empathy to include the family is just one my little bit of suggestion at this point of time. I wish I could expand more on that, but we are really short of time. If anybody wants to comment on that, we can take one or two comments before moving on to the last point. Jen, if you have any comment to make, please do.
No, I think most of us actually agree with that. And finally, I think we have discussed the last point through our various comments. You know, similar situations in a resource limited setting like ours is a challenge, especially like 5 days of ICU where you're not doing anything, you're not except changing the dose of the inotropes. You know, having that in India is not something that I would say is ideal. And I think Dr. Ravnish also mentioned it again in terms of how it is being used as to drain costs. So if anyone else has any comments, they're more than welcome.
Dr. Avnish Khare, yeah, has put in a lot of comments. Courses unshareable for its institute. Yeah, everyone in present healthcare bracket sick care is ignoring the elephant in the room for their own convenience. I think we need to talk more about this open. Yes, totally agree, Dr. Avnish. This is
This
something.
last point
Communication is
summarizes.
something that we really need to talk more about. Only in decreasing PEEP and HSI-NOT. Yeah, yeah, I totally agree. I totally agree, Dr. Avnish. We had to be more than medical technicians because as a doctor, we have to be a friend, guide, and philosophers to our patient and families. And I think we are really running out of time now. So thank you, Dr. Vinayak Jain, for that excellent presentation and the discussion. Really enjoyed, uh, you know, you being on board. It was an excellent, one of a very good experience with your presentation and the discussions. Really enjoyed it,
Thank you,
and
sir.
more importantly, I'm sure that it was a great learning point for everybody. It was for me. I'm sure everybody who participated really benefited from your presentation. And thank you everybody for your input and your patient hearing. And we will meet next week. So thank you again. I think we'll stop here. Rajlakshmi, can you please take over?
Thank you, Dr. Biju, for that wonderful session, sir. And thank you for making it more informative and more discussive point of view also. So I think it's time for us to wind